The Sine Institute of Policy and Politics is American University's incubator for policy innovation. We convene leaders in the academic, public, private, nonprofit, and journalism sectors to engage and promote common ground and nonpartisan solutions. In an evolving world, we seize the opportunity to work on the nation's most pressing challenges through collaboration by experts and top scholars in their field with students in research and scholarship. As part of that goal, the Sine Institute leverages American University's location in our nation's capital, the nexus of government and a growing international business center. We connect diverse perspectives from around the country and around the world with our world-class academics and research, experienced practitioners, and the most politically active student body in the U.S. We stand apart through our focus on the role of business and the nonprofit community in public policy, the rise of the importance of economic regions in the United States, and international policy issues. Our focus is to make an immediate impact at the intersection of policy and politics that leads to real and lasting change. Thank you for joining us as we convene, communicate, and collaborate.
All right, let's get started. Hello, everybody. Welcome to the Sine Institute Fellow Seminar today. My name is Caleb Brown, and I am a graduate assistant for the Sine Institute. On behalf of Sine and myself, we are so pleased that you are here to join us for this event. The Sine Institute is a laboratory for university-wide collaboration and an incubator for policy innovation, convening the best and brightest in the public, private, academic, and nonprofit sectors, as well as journalism. The Institute is where the brightest minds engage to promote common ground and nonpartisan solutions. It is where American University comes to convene, communicate, and collaborate. Today, we are honored to have Sine Fellow, the Honorable Mimi Walters, who will later be virtually joined by our featured guest, Dr. Karen Murphy. Mimi Walters is a former U.S. representative who represented California's 45th Congressional District in Orange County from January 2015 to January 2019. Ms. Walters has served on the Republican Elected Leadership Committee, as well as the influential House Energy and Commerce Committee. Prior to her election to the U.S. House of Representatives, Ms. Walters served on the Laguna Niguel City Council and subsequently served in both the California State Assembly and the California State Senate. Ms. Walters possesses a background in business, finance, and government, and currently serves as Chief Commercial Officer for Leading Edge Power Solutions. Her guest, who is joining us virtually here shortly, Dr. Karen Murphy, is Executive Vice President, Chief Innovation Officer, and Founding Director of the Steele Institute for Health Innovation at Geisinger. Dr. Murphy has worked to improve and transform healthcare delivery throughout her career in both the public and private sectors. Before her current position, she served as Pennsylvania's Secretary of Health, addressing the most significant health issues facing the state, including the opioid epidemic. She is an author and national speaker on health policy and innovation. Ms. Walters has joined us on campus today to discuss the U.S. mental health crisis and the potential solutions for this crisis that is facing the United States and the world. Through this issue, she will help us navigate through the history, causes, and potential solutions available and the ways in which we can find consensus on this important issue. Please join me in welcoming the Honorable Mimi Walters.
Thank you everyone for coming, and it's great to be here. I'm going to be behind the podium today because I have to use my cheat sheets. But anyway, it's wonderful to be here. And just briefly, in our last class, we had an overview of mental health, and we discussed the type of disorders, and we had statistics such as 1 in 5 adults currently suffer on an annual basis with some type of mental illness. We also discussed the most significant challenges facing mental illness, stigma and discrimination, limited access to mental health care. The cost, of course, is very expensive, and social factors such as poverty, homelessness, and social isolation. We had the fortunate chance to talk with Dr. Stone, who shared his experience as a clinical and forensic psychiatrist, as well as his work with the inmate population. In today's class, we're going to be discussing the role that government plays in the private, and we're going to be discussing the role of government and the private sector play in the types of treatments and policies, what is working and what is not working. And our guest speaker, we're so fortunate, and Caleb just mentioned, is Dr. Karen Murphy. And she's going to talk to us as some of the challenges that she's faced both in the public and private sector. So let's first of all talk about who are the stakeholders. Obviously, individuals who have mental health issues, their families, because if somebody is suffering from mental health, obviously there's a ripple effect, and caregivers. There are healthcare organizations out there, such as government agencies, such as the National Institute of Mental Health, which was founded in 1949. And it is the leading federal agency for research on mental health and on mental health disorder. We also have nonprofit organizations such as the National Alliance on Mental Illness, which was founded in 1979. And this is the leading grassroots organization and support group for in the nonprofit sector. We also have professional organizations that are stakeholders, such as the American Psychiatric Association, which was actually founded in 1844, and it's the main professional organization for psychiatrists. Other stakeholders are our insurance providers. Companies like Blue Cross, Blue Shield, United Healthcare, Aetna, they all have a stake in the mental health crisis. Employers, of course, employers who want to have their employees be healthy, they play a role. They can provide education and resources for their employees. And then, of course, we have the policymakers, and primarily on the federal and state level, but you also have policymakers at the local level. And I will tell you that over the last few years, there has been an increased attention that is being played towards mental illness, and people are becoming more and more aware, and we're trying to do away with that stigma, but of course it's only going to take some time. The federal government, for example, funding for mental health research, they've got programs and services. The federal government develops policies that promote access to mental health care and reduce stigma. The state governments, they develop and implement policies as well on a state level that address the needs of their own population when it comes to mental health. They also allocate funds to mental health services and support organizations that provide mental health care. And it's very difficult to really figure out exactly how much money is being spent on mental illness in this country. But I did some research to find out the most recent numbers that I could, and I found out that the White House in 2020 actually released a press statement that's saying that the federal government spent $280 billion on mental illness, and a quarter of that money was spent on the US Medicaid program. And obviously Medicaid, and as people are getting older, mental illness becomes more of an issue as well. And depending on each state and its policies, state spending on mental health is often influenced by factors such as how prevalent mental health is in the state itself, the availability of resources, and of course, state funding and their priorities. Many states, just like the federal government, operate their own mental health agencies, and they have programs, and these agencies are funded through, of course, the state budgets. And I know that Dr. Murphy, having worked with the state of Pennsylvania, will be able to give us a little bit more insight how the states handle their budgets when it comes to mental health. Now, there are billions of taxpayers' dollars being spent on mental illness. So let's examine what policies and treatments that are currently working. First of all, policies that promote access to affordable and evidence-based mental health services, including psychotherapy and medication, have shown to be very, very effective. One example of a very large piece of legislation was the Affordable Care Act that was signed by former President Obama in 2010. And this law created health insurance marketplaces where individuals and small businesses can purchase affordable coverage. I mean, of course, it did a lot more things, but that was one primary part of that legislation. Policies that promote early identification and treatment of mental health disorders, including screening programs and outreach to risk populations, have also shown to be very effective. The Mental Health Parity and Addiction Equity Act, which was signed in 2008 by former President George W. Bush, mandated that insurance plans provide equal coverage for mental health as they do for physical health conditions. See, in the past, they didn't, but as of 2008, they were mandated to. Other effective treatments are community-based services, such as peer support groups and psychosocial rehabilitation programs. We mentioned the National Alliance on Mental Illness, which is a very large support group. Also, psychosocial rehabilitation programs such as the Clubhouse model. And this is a model that was created in the 1940s, and it basically was created in New York in 1948, where a bunch of people got together at a clubhouse and they wanted to talk about mental illness. And they devised a holistic approach to mental health treatment that emphasized social connections, meaningful activity, and personal growth. And other programs that aim to reduce stigma and promote mental health awareness are Substance Abuse and Mental Health Services Administration, which is another government agency. And there's a wide campaign called Stop the Stigma campaign. So all these groups working together are helping to promote mental health awareness. Yet we see these different policies and organizations that are working toward a good common goal. And quite frankly, we've made very good progress over the last several centuries. We really, really have. But yet we're seeing that 1 in 5 adults are still suffering with some type of mental illness on an annual basis. So let's look at the policies and treatments that have been very harmful that we've learned from. Back in the 18th and 19th century, it was very common to institutionalize people and put people in these institutions involuntarily, and they had involuntary treatment, forced medication and hospitalization. That wasn't working. Excessive use of medication, which we still see today without adequate monitoring and follow-up. I shared with you my story of my son at our last class with his bipolar disorder, and we found out he was not taking his medication. That's when he went into his manic state, and that's ultimately one of the reasons he ended up in a psych ward. So it's really, really incredibly important to monitor that medication and make sure that individuals aren't taking too much of it. And then policies that criminalize behaviors associated with mental health disorders, such as homelessness, have proven to be harmful. But that puts us in a very precarious position when you're talking about issues like homelessness, because what do? You have somebody who's out on the street who has suffering from some sort of mental illness, but then they have their civil rights, and should they be forced to be put into an institution? The ACLU will say, of course not. If you were that individual, you probably wouldn't want to either. But elected officials are having to deal with this because our homelessness is such a huge deal in our country. And in my own state of California, Governor Gavin Newsom signed into law in last legislative session, which basically is a court-ordered mental health treatment program that people have to attend. And if they have, let's say, a loved one says this person is going to be hurtful to themselves or hurtful to other people, they can then make them go to court, and then the court would put them through some sort of treatment program. And if they did not succeed in that treatment or that program, then that person would have a conservatorship. And that is something that is one way, obviously, that we're going to have to deal with this issue. Obviously, it's very controversial, but I applaud California for taking the lead and looking at something of that nature. But it's also very important to understand that this is not a one-size-fits-all. that depending on a person's illness depends on their treatment as well. And so you can't just say somebody's ill, so this is what we should do for them. We have to look at individuals separately. We were asked, or I was asked about in the last class, where does science play in this role of policy? And as a former policymaker, I will tell you that science plays an incredibly important role, because policymakers can't make decisions on issues unless they have facts and data. And so we rely on those researchers and those scientists to do the research to tell us what the facts are, so that we can then make the right decisions and the best informed decisions when we're putting forward policy. And you will see in just about every big policy or piece of legislation that gets passed and signed into law, there's always facts behind it. And you just can't have policy without having that research in the science. And finally, what I want to touch upon before Dr. Murphy speaks with us is, the private sector, nonprofit organizations, and media all have significant impacts on mental health disorder, although they have impacts in different way. We talked a little bit about the private sector. Employers can provide employees access to mental health services such as counseling and therapy and employee assisted programs. Many companies also offer mental health benefits as part of their employee insurance plans. And additionally, employers can create a supportive work environment that prioritizes the employee's well-being and mental health. For example, offering flexible work arrangements or reducing workplace stress. Nonprofit organizations, we touched a little bit upon that. They have significant impact on mental health disorders by providing resources and support to individuals and community. They provide mental health education, advocacy, and direct services such as counseling and support groups. And these organizations also work to reduce stigma surrounding mental illness and promote awareness of available resources. And many of the nonprofits also advocate for policies and funding to improve mental health care access and quality. Now, media, how does media influence all of this? And speaking from somebody who has a love-hate relationship with media, I will tell you, it could be very helpful to us with mental health. They can talk about increasing the awareness and telling people's, having people share their stories, and they can bring out compassion and educate people, but they can also perpetuate the stereotype as well. And they can, continue the negative attitudes toward mental illness and lead to further stigma and discrimination. So, it's sort of a two-edged sword when it comes to the media. But overall, the private sector, nonprofit organizations, and media all play an important role in promoting mental health and reducing the negative impact of mental health disorders. So now that we've gone through this overview, we're going to hear from Dr. Karen Murphy, whose career has been in the mental health field, serving in both the public and private sectors. And she's going to be able to give us an insight to the reality of what she has faced and currently faces in dealing with this crisis. And then after she speaks, we'll take some questions, and I'll lead us off with the first question. And so with that, Dr. Murphy, thank you for coming. We are so happy you are here, and the show is yours.
Well, thank you so much. I'm trying to get off video, but it says the host has stopped it. So
Better technology.
maybe we'd like to let me try it again. Nope, still says the host has stopped me. Well, let me start.
We're just trying on our side. One more thing here. We
Okay.
have an expert here. There she is.
There we go.
There, we got you. Good job, Caleb.
Good afternoon, everyone. It's a pleasure to be here, and thanks so much, Mimi, for inviting me. This is a subject that I frequently talk about, and after being in healthcare for a very long time, it's almost shocking to me that we have a behavioral health crisis in this country and we're doing so little. So while we just heard the federal government really beginning to intervene and state governments are doing the same, it's, I believe, really minimal intervention compared to what is needed. And it is an area in healthcare that has been starved truly for decades. So I would say that historically, behavioral health needs really started to rise in the late 70s when the federal government decided, along with state governments, that individuals with severe behavioral health needs at that time were institutionalized in mental institutions where they received inpatient care, counseling, medication, were released, but there were people at that time that had spent decades in those institutions. And the thought was that if they closed down the mental institutions and offered outpatient care, that individuals would do better in society, and that they would be able to get adequate outpatient services in a much more cost-effective way. I'm not advocating for mental institutions, but I can tell you that that is a policy that has really severely unintended consequences. So when you look at the homeless population, those individuals 30 years ago would have had 3 square meals a day. They would have been helped with their problem, and hopefully would have been transitioned to an outpatient counseling and been given social services. That was the idea of all that. Well, none of that really took place. This country today is underserved in terms of behavioral health. And I mean to an extent, both in the private and public sector, that has led to severe mental health disorders that have really impacted society, families, in a very unfortunate way. So you heard my background. I just tell you the story. I worked at a community hospital for many years. And I started my career out as an ICU nurse, so very aware of clinical medicine, and then went into administration. And I left that organization as president and CEO in 2012. And while we heard, and I live in a community in northeastern Pennsylvania that's suburban, and we pretty much have, I would say, issues that mirror urban areas, but on a smaller scale. So I was very in touch with the community, very in touch with both physical and mental health needs. And when I left, I would say on a scale of 1 to 10, drug addiction at that time in that community was maybe, I would say, at a 3. I went to the Center for Medicare and Medicaid Innovation, worked in federal government, and then came back 2.5 years later to the state of Pennsylvania as Secretary of Health. And I was astounded at the acceleration of the opioid epidemic that was hitting not only Pennsylvania, but the country as a whole. And that we were losing, at that time before the pandemic, we were losing 70 lives a day in Pennsylvania due to overdose. And, pre-pandemic, we were pretty sensitized to something that is an interventional that we have the ability to intervene and actually treat the problem. Before COVID, 77 lives a day was pretty substantial. So started as Secretary of Health really to look at what kind of state policy that we can really intervene in the area of addiction, not just opioid addiction, because there are many addictions to many other drugs, including alcohol, that are really negatively impacting not only the individual, but the family and families involved with that individual. So the first thing we did was sign. At that time, the drug to reverse opioid overdose was naloxone. And it was very hard to get a prescription for naloxone. So the physician general, the first thing we did the first 2 weeks that we were in the Department of Health was to sign a statewide order so that individuals could have access to naloxone. So we would educate, create policies for therapy, create a 100 number to seek counseling. But it was very clear to me that there was not adequate services in the Commonwealth of Pennsylvania. And that really is the story everywhere. That was number one problem. I think the second problem that was very clear to me too, both at a federal and state policy level, is that the stigma associated with behavioral health needs is so severe that it has truly negatively impacted us as a country moving forward to treat behavioral health needs, including addiction. I would say addiction is probably the worst with stigma, because people look and for some reason they think it's a willful behavior that could easily be stopped, which is nothing further from the truth. It's also a physical addiction that takes place. But because of that, really hard when you're competing for dollars for other issues. If you have the mentality that this is something that people are choosing. And I always use the example that I say, when I was an ICU nurse and a diabetic came in that was overweight, I never thought, like, you're in critical condition, but you could have avoided this if you lost weight and you took your insulin and you didn't eat the wrong things, or God forbid, a dialysis patient that knew they shouldn't drink more than a 30 cc, which is like a medicine cup of water a day, but you knew you shouldn't do that, but you went ahead and did it anyway. We never thought that. We never thought that if you have an addiction that you shouldn't be, or if you have a chronic disease that is influenced by your lifestyle and by your choices, we never once thought maybe we should give less treatment or we shouldn't do the most for this person. But in treating behavioral health and being involved in establishing policy, clearly the stigma has worked negatively towards advances in behavioral health. I always say to my counterparts, my colleagues, that picture you're an emergency room physician or nurse, and you go out to the emergency room and 30 people are having a heart attack. The first thing you would do is prioritize those patients in severity. You would get them back into the emergency room, administer the treatment to save their life immediately, and then go back and get each of the level of patients that are triaged. And that's really what we're looking at with the population of behavioral health, people who have behavioral health needs. So we have the highest that require serious intervention with medication. This would be your schizophrenic that is really not prescribed adequately, or bipolar disease individuals that really cannot function because they could function if they have medication, but they don't have the treatment. And then we have individuals that suffer from, I would say, severe cases of those diseases that a lot of people have in this country. And that is severe depression, severe anxiety that really stops in their tracks. They can't get out of bed every day. They can't function. That's another level of therapy that is needed. And then we have those that are putting the good face on, taking the steps forward, and going out every day to try to function, but they're disabled in their own mind with depression or anxiety. And the quantitative magnitude of that population is just incredible. It was incredible before the pandemic, but the impact of the pandemic on behavioral health and the light it shone on the fact that we don't have adequate services for behavioral health is truly incredible. At Geisinger, we are a 7-hospital integrated delivery network. We have our own health plan. We're in 23 counties in Pennsylvania. We have a clinical enterprise, doctors, along with those hospitals and health professionals. We have about 25,000 employees. During the pandemic, and rural and suburban communities that we serve. During the pandemic, at one point, we had 9,000. Now, this is just for Geisinger Health System, relatively, I would say, not super large, that we're talking about millions. We're probably talking about serving 3 million people a year. But we were backed up 9,000 referrals during the pandemic for behavioral health needs. So someone needing the most severe that I talked about, to someone needing a psychologist versus a psychiatrist, someone needing a social work to find food that was causing anxiety for their family. 9,000 people we couldn't get to, and they were all grouped in the same way. So in healthcare, physical healthcare, that never takes place. We could tap on the shoulder of any physician that we know and say, give us the disease you treat and give us the buckets of severity. With behavioral health, unfortunately, we lump it all together and tend to take very generalized approaches as opposed to targeting the populations that we need. So at Geisinger, I'm very proud of the work that we've done in behavioral health. A couple things that we've done. I work in innovation, and the director of the behavioral health program called me and said, I have these 9,000 referrals that need to see doctors. I don't have the doctors. I don't have the social workers, and I don't have the support services to even get through this backlog. It'll take me years with what we have. So what we did was we went out to a company that provides psychiatric services, psychiatrists, psychologists, social workers, and we pulled psychiatrists and psychologists from all over the country. So we were able in 90 days to get that number down from 9,000 down to probably in 90 days, probably in a third of what we originally had, and we've since worked that backlog. But that was an innovative approach that we used to really help all those individuals that needed help. And they became, even though they were in states across the country, they became similar to our medical staff in that they were embedded virtually in the Geisinger system. We've done other work in expanding with mobile clinics to go to crisis centers. We have partnered with our primary care doctors to help them be able to have the tools necessary. For addiction, we have 43 work streams to deal with substance abuse disorders. They are pretty general in terms of medication-assisted treatment. One that I'm really proud of that we started in 2019 was a program called Free to Be Mom. So it's the word free, the letter 2, capital B, mom. And it is a program for moms that have substance abuse disorder that are pregnant. And we try to intervene when they go on medication-assisted treatment as soon as possible after the medication-assisted treatment starts. And we wrap our arms around them with community services. And so it's not medical care. It's really, how do you get food? How do you get counseling? How do you do preparation for a job? After the baby's born, what can we do for the baby? How do we get you a pediatrician? How can we plan for your future? And the goal is really to increase the probability of moms staying in recovery. So they're pretty much the innovative approaches. They're just a couple of examples of what we're doing. We are really trying to work on the stigma at Geisinger and trying to educate on the stigma of not only addiction, but also behavioral health. Behavioral health is every bit as equal as your physical health is. It is as debilitating and also as interfering with your life, I always say, as if you needed an organ transplant. So, I think the takeaway message for you today is it's going to be incumbent upon you to continue to evolve in thinking, continue the organizations that you work with, almost be like a prophet in terms of fighting for the needs of behavioral health, both programmatically and policy. I think until we keep the noise level up as loud as we can, we need federal policy, we need federal dollars, we need state dollars, and we need public-private partnerships to address this really, really crippling issue, and really to address individuals that have great needs. So I'll stop there, Mimi, and happy to entertain any questions.
Well, thank you so much for your insight. And I think I'll start the questions off, but based on your experience, what would you say, and it could be stigma, but what would you say is the biggest challenge that you think we face with this mental health crisis?
I think stigma is the underlying. I think we're trying to work on leveraging that or decreasing that profile, but I think it's there to a great extent, and we have to decrease it. I think the other piece is we have to make it attractive for health professionals to enter the world of behavioral health. In our area, we are short on every single level: psychiatrists, psychologists, social workers, community health workers that we could use to intervene, develop interventions. There is a national shortage. I think the virtual way is a good way of trying to leverage behavioral health and kind of balance out. When I was Secretary of Health, I used to say Philadelphia and Pittsburgh don't need my help because they have, I was blinded by a sea of white coats. They have so many doctors in those urban areas. But when you start getting to the middle of Pennsylvania, which is very rural, they have effectively no access, and very difficult to get a doctor or a clinical social worker to get out to those areas. I think we're going to have to depend on innovative approaches to really augment. And I think the other part I talk about triage is reserving the human intervention for those that need human intervention and develop other capabilities that perhaps don't rely on humans. But for that lower rising risk population, I think there's interventions that we can develop. I think the shortage of funding is woefully inadequate. I think it's better than it was, but I think we really have to start walking the talk. I think, you know, everybody pleads that that we need funding for mental health, but I think competing priorities really take a much larger role in federal and state budgets.
Yeah, I think a lot of that is the more elected officials talk about it, the more become aware of it, then it becomes more of a priority. And that's what we have to make sure it happens. We'll take some questions from the audience. Anybody have any questions?
That may be like a more fact-based question. If you don't know at the moment, that's fine. But you mentioned earlier that the budget for mental health illness, mental health care, was $280 billion, and a quarter of that went to Medicaid. I'm kind of wondering where the other 3/4 have gone and what we're already sort of funding.
Well, a lot of that goes in Karen, feel free to jump in, but a lot of that goes to the different support groups out there, the different government agencies who are trying to administer mental health services. That's where a lot of it goes. You know, if you look at HHS, which is the Human Health Services, I mean, they have, I don't know, within that, they probably have 27 different agencies that deal with, you know, mental health. And so money gets spread out through all those different agencies. But Karen, can you expand on that a little bit?
Sure. Could you just repeat the question, Mimi, so I can be sure that I heard it correctly?
Yeah, so I had made a comment in my talk about, I had seen the White House had come out in 2020 and said that $280 billion had been spent by the federal government on mental health. And the young lady wanted to know, because 1/4 of that was spent on Medicaid, and she wanted to know where the other, you know, 3/4 of the money be spent.
So that's a great question. So Medicaid is funded by both the federal and state government. So I would say 1/4 of that is of what the spending was on the federal side, and then states go ahead and supplement that behavioral health spending also, because they are responsible for 50% of the cost of Medicaid. Of the Medicaid spending as a nation, of that 1/4 and all that the states spend, the major diagnosis, the highest spend is on behavioral health. What the remaining funding, and I can just tell you buckets, I can't tell you specifics, but the remaining goes to definitely fighting the opioid epidemic or drug addiction. Funding community organizations. So the government understands that we really can't fight this war on our own. So community organizations that you see in your communities receive both federal and state funding. And what I mean by that is, say, food banks for those that are homeless, food insecure individuals. They can get federal and state funding. A good portion goes to research that's awarded to drug companies to develop drugs that are effective in the behavioral health realm. The other place that it goes is to individual groups that are vulnerable. So that would be moms and children that have behavioral health needs. It would be older adults. And as Mimi said, there's several health agencies within the Health and Human Service
Yeah.
agency that addresses, I would say almost all of them right now addresses mental health as a part of their budget.
Thank you.
Throughout the conversation, we continue to address the mental health crisis, and we use that word. What do you propose from your experience is the ideal state where, like COVID-19, the government, either that's federal or state, can almost declassify the mental health crisis? And, what Biden is going to announce about, COVID-19's over. Do you think the mental health crisis will ever get to that state of being over or classified as such?
No, I don't. First of all, for this reason, the numbers of individuals with those diseases that I talked about are not going down, they're going up. So the behavioral needs in this country is actually increasing. Very difficult when you have a crisis up here to catch up. I don't think there'll ever be, because of competing priorities. We have education, we have physical health, we have infrastructure needs. There is not enough money to put in the system at one time, like a jolt, like we did with COVID. So the last 2 years, the federal government flooded the drug companies to develop vaccines, and there was a beginning and an end. The virus burned out. Mental health issues are never going to go away. They've been here since the beginning of time. The issue that we have now is the magnitude keeps increasing. It's not decreasing. We haven't found anything like a magic pill that takes it away. So no, I don't think the crisis will ever end. I don't think we'll ever, because of the competing priorities, I don't think we will get to a place, certainly in my lifetime or yours, that we will say we've solved the mental health crisis. My hope is that we get to a place that we say we've provided adequate access to those that need it for treatment that they need. Like that to me is a true north. And I don't know if that'll be seen in the next 20 years.
Yeah, I was curious about the backlog during COVID that you saw, the 9,000 people that you weren't able to treat. And that part of me wonders if some of the need was from a change in circumstance, like loss of job or change in financial status, which can really bring on a lot of anxiety and depression in people that seek treatment. But what proportion of that 9,000 was, once you were able to find the care, was people who maybe did see a loss of employment during the pandemic versus like those who needed serious interventions and help?
So in terms, because of the federal government's regulations, we're not really permitted to, I'm just saying, so even I at Geisinger don't know how many of those, what they were caused by, but I can tell you general trends. So the ones at the highest level of disease ended up in the emergency rooms, staying there literally 36 days with one-on-one observation because they were in a mental health crisis. We couldn't find placement for them. They'd get COVID. Nobody wanted to take COVID. So that's a good portion. They would be individuals that had mental disease before COVID, but some way, somehow were cut off from their healthcare provider that kept them stable. So that's one class. I think all other classes that of that 9,000 that I would say either were in the system or came in the system because of COVID, clearly COVID impacted mental illness severely and added people that weren't mentally ill before. And that was definitely brought on by the social isolation that we had to have because of the pandemic. And it was brought on because of the numbers of healthcare workers that left because they were left healthcare because they were overwhelmed. And the access issue was actually impacted. So like, I would have to say to you that I would say, and this is just a guess, that 10% were probably the severely mentally ill that landed in emergency rooms, not a place for people who are mentally ill. I would say the next 30% were people who had problems before, lost access, and I would say they were the class of like severe depression, bipolar disease, and then there was that newly diagnosed group of really severe anxiety and depression that was brought on either in a change of life circumstances, a love of a lost one that died because of COVID, or an individual that just couldn't find access to treatment and were socially isolated.
Hi, thank you so much for coming today. You had mentioned the rural versus urban disparity in healthcare access. I'm curious if there have been any trends that point towards maybe a more equalized access regarding behavioral services in rural areas.
So because Pennsylvania is so rural, like I said, somebody once said Pennsylvania is comprised of Philadelphia and Pittsburgh and Alabama in between. So most of our state, we have a huge rural population. I think the only way we're going to be able to serve rural areas effectively is to rely on virtual care, because the shortage of psychiatry is just so immense that I think it'll be very difficult. Or unfortunately, which I think is awful, because I don't think people should be disadvantaged because of where they live, access to healthcare. But like what's really lacking in rural communities is like counseling, adolescent counseling. But I think virtual offers us promise in the way that we can better serve our rural communities than we did before.
Why don't we go to him and then.
Thank you for coming. When talking about, the deficit of like healthcare workers, especially in mental health, have you seen any organizations or state governments, or maybe what the federal government's doing to like invest in the pipeline, knowing it won't be solved like next year or the year after, but like what we're doing to try and build up?
Sure. So there's definitely very innovative approaches by the federal government, state government, and I'll give you one at Geisinger. So we have a medical college as a part of the Geisinger health system. And 3 years ago, we started the Abigail Scholars Program, and the Abigail Scholars are named after Abigail Geisinger, who founded Geisinger in 1815. So the Abigail Scholars Program offers free tuition for medical school students that go into primary care, psychiatry, and for that, they have to stay in our communities when they complete their residencies and become practicing physicians. They get medical school for free for a 5-year commitment. So our hopes is that many of them, and we've seen an uptake in psychiatry, will then come back and serve our communities. So I think that's a great example of an innovative approach to try to increase the pipeline. I think the other piece that very important is social workers play a huge role in mental health, and they have not been, I don't think, paid adequately. And I think it's a supply and demand issue. I think due to the demand, we're finally getting the social work worker, not completely adequate, but better salaries and income. And I'm hoping that will incentivize individuals to go into the profession as well. Psychologists are a little different because, and so can psychiatrists. And what's exacerbating the problem is that many of them can do selective psychiatry and psychology. So they can say, I'm not taking any insurance. I'm not going to take this type of, I'm not going to take these problems. I'm only going to treat these. And it's going to be a self-pay, which is extremely expensive for people. So we have to keep our eye on not only the number we produce, but also something with the ethical license that allows us to have equal distribution, so that individuals can have access to services.
Thank you.
So I also come from a rural part of Ohio. So when you're talking about rural Pennsylvania, I think a lot about my own home. And something that there's been a lot of conversations about amongst my friends at home is they're literally closing down clinics and hospitals because these hospital systems are losing money on the sort of more local clinics. Is there a way or some kind of policy or some sort of program where you can incentivize hospitals to not close down places where you need access just because they're maybe not turning a profit? Because that's kind of a big deal, I think.
So I could do a whole other class on rural hospitals.
Yeah.
Because when I was in Pennsylvania, and like I made that comment about Alabama in between, I worked as Secretary of Health with the federal government on restructuring payment for rural hospitals in order to give them a sustainable business model. It is very complex. And I just spoke on a conference the other day and I had some of the federal government people with me, and I said, we have to decide as a nation that we are either going to fix rural healthcare or we're not, because this playing around the edges is really not helping anyone. So I do have to say the federal government is really trying to find ways to change the reimbursement model to a sustainable business model. And then rural hospitals, they have to allow them a glide path to pay them to really do what they do well, because you're not going to have open heart surgery in a rural hospital.
Yeah.
You wouldn't want to, I mean, in terms of quality, frequency, but we do need, at my earlier comment, I don't think it's fair for individuals to be disadvantaged because of the address they have. So I think that's a great question. There is a national movement to try to figure this out, because hospitals are closing daily in rural communities because they just can't sustain it. And it's not only health sustainability, but it's always the rural healthcare system is the economic engine of some of these, most of these communities. So it provides jobs, it provides ancillary benefits to the other businesses in the community. So huge problem that is very important for our country to address as a whole.
I think we have time for one more question. Did you have one more question? And then we'll let you go, Dr. Murphy. Thank you.
Yeah, I just wanted to ask about the selective like insurance policy of psychiatrists and psychologists. Is there a way that policymakers could work with insurance companies to help address that issue with doctors? Because I'm curious about that.
Yeah, it's not really. So there's a couple reasons why they do this. First is there's a tremendous amount of red tape associated with dealing with insurance companies and Medicare and Medicaid. So your overhead goes up because you have to pay people to fill out the forms, to keep track of what you got paid. That's number one. Number two, quite frankly, it's just easier to collect cash or a check. You don't have, if there's no license requirements to say you can't do that. There's nothing wrong with, I mean, in terms of the law or the profession, you certainly have the ability to pick who you want to see. I think where we really have to change, as a country is to figure out a way to get our Medicaid individuals seen. And for that, you have to create a financial model that incentivizes psychiatrists to go into that model as opposed to private practice.
Well, thank you so much. This has been very informative. And keep up the great work. We appreciate it so much, Dr. Murphy.
My pleasure. Thanks so much for having me. Have a good evening, everyone.
All right, thank you.
Thank you.
And before I let everybody go, I wanted to just let you know about our next class, which is going to be on March 28th at 4:00. I'm going to have an in-person guest, and I may have mentioned to you before, my son-in-law went through a trial at NYU where he was administered psilocybin to help him with his alcoholism. And he's going to come share his story with you all. We're doing a lot of work on Capitol Hill right now in this space, trying to get some support from Congress. And so he'll be here to share with you his story and what we've been doing. And he's done a lot of national press as well. So I think it will be a really great class. And so I hope you all can make it on March 28th at 4 p.m. Thank you.
Thank you, everybody, for coming. On the table in front of you is a little flyer. You can scan this QR code to register for all the other events and sessions coming up. There's career conversations, which are really cool, and you're going to be able to talk to each fellow about their career and how they got to where they're at. So check all that information out. We have one more session before spring break with Anna DeVere Smith on Thursday, and that's going to be virtual, and then we have a lot right that week after spring break. So thank you so much for coming, and let's give another round of applause for me.
And my associates who are here, I'll see you on Thursday night.